Hello, everybody, and welcome to another edition of the SABCS Snippets. My name is Virginia Kaklamani from UT Health in San Antonio, and joining me today, I have the pleasure of having Dr. Komal Jhaveri from Memorial Sloan Kettering, who is the section head for the Endocrine Therapy Research Program. Kamal, we just had a nice announcement a few days ago about the results from the VIKTORIA-1 trial. So you want to summarize the trial for us and kind of give us what your highlights are?
Yeah, absolutely. Thanks for having me again. Always fun to do these snippets and, putting all these newer data that are coming out into context for everyone. So, yeah, we were talking about the press release that came out on a Monday, July 28th, on the phase 3 Victoria-1 trial, where they reported out results from one of the cohorts, actually, which is the PIK3 wild-type cohort. So, a long time we've not had the wild type patients have a new data set come out. So this was exciting from that perspective that we were getting newer data from the wild type. So what did the trial have? It entails gedatolisib, which is a dual PI3K and an mTORC inhibitor, what we now call as a PAM inhibitor. I thought that was an exciting new acronym that we can use, a PAM inhibitor, but that's a dual PI3K mTOR inhibitor. And they studied three arms in this cohort. One was looking at gedatolisib with fulvestrant and palbociclib. Another one, gedatolisib with fulvestrant. Sorry, it's a mouthful. And the last one was fulvestrant. And so what was done was that the triplet was compared to fulvestrant alone, and the doublet was compared to fulvestrant alone. And what we heard was that the triplet yielded a median PFS of 9.3 months compared to 2 months with the fulvestrant alone arm with a hazard ratio of 0.24. So really an unprecedented hazard ratio. We haven't seen such a hazard ratio in HR positive metastatic breast cancer, let alone we haven't seen this in PI3K wild type tumors. And I think this is the first time we're seeing some triplet data in the PI3K wild type tumors as well in the second line metastatic setting. So the doublet arm was also compared to fulvestrant. So gedatolisib plus fulvestrant yielded a median PFS of 7.4 months compared to 2 months. And there the hazard ratio also was 0.33, which was statistically significant. So both were statistically significant. And to put the trial into context, this is a second line study predominantly, or second or third line, I guess. We'll hear more details when it's presented at an upcoming conference later this year. But these are patients who have been treated with an AI and a CDK4/6 inhibitor in the first line metastatic setting. No more than 2 lines of endocrine therapy were allowed, and then they were enrolled to this study. And this was one of the cohorts where these three arms were, studied. And so I think when I think about the results, what excites me the most about it is the triplet arm, because we've seen recently that triplet strategies have been beneficial. I mean, we first saw those results from the Summit trial with neratinib, trastuzumab, and fulvestrant, where we learned that the triplet, landed up being better than the doublet and monotherapy, which was an adaptive way of studying it in the Summit basket study. And that led to a Category 2B NCCN endorsement for that regimen for ERBB2 mutant tumors. And more recently, I think our treatment paradigm has been changed in the first line metastatic setting for PIK3 mutant tumors with the addition of inavolisib with fulvestrant and palbociclib in the first line metastatic setting, something we had heard at the San Antonio breast cancer meeting 2 years ago. So I think we are recognizing as a community that maybe comprehensive blockade and trying to combine or target 2 or 3 pathways simultaneously can yield better results and certainly can potentially address endocrine resistance mechanisms better. And so from that perspective, I'm excited about the triplet. I think the one thing that we need to probably focus on when we hear about the data. So one, we would be interested to understand what proportion of patients say would be ESR1 mutant. We don't know that because we now have biomarker-based treatment selections in the second-line metastatic setting. We offer single-agent LSS-trend, a study that you were very deeply involved with, Virginia. And we have that option available from the Emerald study. We have, PI3K inhibitors. We have capivasertib AKT inhibitors for PI3K mutant tumors and capivasertib also for PTEN and AKT altered tumors, which is a doublet regimen that we utilize in the second-line metastatic setting. And when we think about the ESR1 wild type and the PI3K wild type, we usually think about fulvestrant abemaciclib. something like post-monarch, so CDK4/6 beyond progression with abema. And then we think about fulvestrant and everolimus, something that, we also offer our patients, although we don't have for fulvestrant everolimus a prospective, phase 3 data set post CDK4/6, which is why the control arm here potentially was fulvestrant alone, appropriate at the time when the study was designed. So I think it'll be interesting to look at all that. And then second thing that I think will be important to focus on would be that gedatolisib, interestingly, unlike the other agents targeting this pathway, is an intravenous infusion. And that potentially could have some administrative logistical considerations in clinic because it's weekly, 3 times given, 3 weeks on, 1 week off. And which is unlike what we've been doing in the second, third line setting, where we are, trying to push chemotherapy or intravenous regimens later down the line, and we don't necessarily have targeted regimens which are intravenous. So that could be an interesting one to focus on. So I think I would love to see those data. And last but not the least, I think the press release suggested that the safety and the tolerability was better than what we have seen in the phase 1b. And what are we referring to? We're referring to hyperglycemia, we're referring to stomatitis, we're referring to rash. And that makes sense. In the phase 1b, they did not allow any primary prophylaxis. I'm assuming the phase 3 did allow primary prophylaxis, say for stomatitis or for rash. But I'd love to see those details, the granular details of the safety tolerability data to put all of this into context as to how should we be thinking about doublet strategies? Should we be thinking about ESR1 mutant distinctly? Should we be considering everolimus? And then what would happen as we hear more and more data sets with novel endocrine regimens and novel agents targeting the PI3K pathway, or novel agents such as oral SERDs in combination with abemaciclib if they become available in clinic. So a lot more to learn, but needless to say, exciting data. Looking forward to seeing more details.
So you just mentioned this, and you didn't mention the trial that you're the PI of, the EMBER-3, where the combination of imlunestrant and abemaciclib in this pre-CDK treated patient gave a relatively similar median PFS of 9.1 months.
Yeah.
So 9.1 months with a doublet and 9.4 months with a triplet. So assuming this is the data we're going to have, and assuming the FDA approves all of these combinations, how do you see this post-CDK setting evolving in the next couple of years?
Yeah, I think there's going to be a lot more evolution than what we've been seeing. I think, as you can tell, with the amount of data that we've been discussing just in 5 minutes, it has been really evolving over the years. And I think it is just going to continue to do that. And you pointed out EMBER-3, and that's an excellent point, because EMBER-3 obviously looked at the subgroup of patients which was post-CDK, but they also showed that the doublet of imlunestrant and abemaciclib worked with or without an ESR1 mutation. In fact, with an ESR1 mutation, the doublet itself gave us 11.1 months. That's not trivial. That's exciting. And then when we think about the ESR1 wild type, it was still 9.1 months. And so, as you said, how will that compare, or how do we think about that? Now, within VIKTORIA-1, we cannot address that. We don't have a comparison head-to-head of imlunestrant abema with, say, fulvestrant abema. Within VIKTORIA-1, we don't have the comparison of the triplet with a doublet that included everolimus or an agent targeting the pathway. We might soon hear data from, say, the IVERA trial, which is evaluating giredestrant, another oral SERD, with everolimus compared to physician choice endocrine therapy at everolimus. So I think we're going to learn a lot more about all of this. And then depending on how the regulatory agencies provide these approvals, whether it's happening with imlunestrant alone, whether it's happening with the doublet, the timing of all of that, and our further understanding of further subgroups within the VIKTORIA-1 trial, we might be able to tease out a little bit better. But right now, it does seem like for, say, the 35% of patients who might be both ESR1 wild type and PI3K wild type, should the VIKTORIA-1 lead to regulatory approval, we have an option available for patients to be utilized in that setting. And then we will have to figure out which doublet or triplet makes sense. We'll discuss the toxicities, the administration schedules, patient preferences, and make a patient-physician decision-making process.
Which is exciting because we've had the first line therapy lasting, a median of 24 or so months. Then we have the second line that up until recently, we were talking about 2, 3, maybe 4 months, and now we're getting to 10 to the 12 months. So I think obviously just benefiting our patients, which is going to be just a wonderful thing for us to have in clinic.
Yeah, I will not be complaining about all the embarrassment of the riches of having so many options available that we can look into and figure it out and discuss with our patients. So I think good progress and good excitement from that perspective. I think we need to continue to focus on, can we further optimize these outcomes? Can we find the best regimens that we can offer? How can we sequence these regimens, and how can we optimize toxicity management so that we can really make a big difference in the metastatic setting for our patients?
Yeah, well, I'll finish with that because I think that was the best message. Thank you so much for joining us today. Thanks everybody for listening in, and we will see you soon. Thank you.
Absolutely. Thank you so much.